We're going to go live in 3, 2, 1.
Good morning, everyone. Welcome to the second session today for our Hypoparathyroidism conference. It is on diagnosis and advances in management. But before we start that, a few housekeeping announcements. Again, remember your mics are muted, so you will not be able to speak during the presenter's presentation. If you need to ask a question, just use the little chat function to ask the question and I will ask it for you. If we do not get to all of the questions during the presentation today, we will keep those questions and try to get them answered for you and post them on our website at a later time. Also, I forgot to mention a few people during morning announcements this morning. So we would like to again mention all of our sponsors. Thank you to Amylite, Ascendis, Takeda, Calcilytics, and the Hypopara Research Foundation. If you would like to visit with any of those sponsors, go to the VCM button on the left-hand side of your page, and where you see at the top of the page, it says Expo Hall, click on that, and up will come their logos, and you can click on them to either use the chat function or look at their websites and documents. Also, one more thing, we have a silent auction going. To access the silent auction, just click on the Teams logo on the left-hand side of your page. You will see a list of items come up. You will click on the individual items to view the items. You will see pictures, which you can double-click the picture to see it bigger. And there will be a chat function underneath each individual picture. That is where you bid, is underneath the chat function. If you have any questions about the silent auction, you can chat us in that area, and I will respond as quickly as possible. Now on to our presentation. I would like to introduce to you Dr. Khan. She is a professor of clinical medicine in the divisions of endocrinology and metabolism and geriatrics at McMaster University and the director of the Calcium Disorders Clinic at St. Joseph's Healthcare, McMaster University. She graduated from the University of Ottawa Medical School with honors and completed postgraduate training at the University of Toronto. She has published over 100 scientific papers on osteoporosis and parathyroid disease, as well as numerous book chapters. She is the, editor-in-chief of the Handbook of Parathyroid Diseases. Dr. Khan has been recognized by national and international awards, including the International Clinician Instructor of the Year 2011 award by the International Society of Clinical Densitometry, the Queen's Diamond Jubilee Medal for 2012 for excellence in clinical care, research and teaching, as well as the International Hypoparathyroidism Award for 2014. Without further ado, I would like to introduce to you Dr. Aliya Khan.
Thank you so much, and welcome everybody. So I'm going to be talking about advances in medical management for hypoparathyroidism. And if you have any questions, feel free to forward them to us, because I want this to be a useful learning opportunity, and I would like it to be interactive. I have been involved in clinical research and the development of new molecules for parathyroid disease, and I have received research funding from a number of the industry partners. And so what we're going to talk about is how do we diagnose and manage hypoparathyroidism, and how can we best utilize the resources available to us? So I wanted to begin by saying that the parathyroid hormone is really the key regulator of serum calcium. And when serum calcium goes down, it's sensed by the calcium sensing receptor, which is sitting on the chief cells in the parathyroid glands, and that stimulates the synthesis and release of parathyroid hormone. And what happens when we have an increase in parathyroid hormone is within minutes, we're able to reabsorb calcium through the kidney. Every day we filter 10 grams of calcium through our kidney and we reabsorb 9.8 grams. For those of you who take calcium, you may be taking a gram of calcium once a day, one pill, maybe 2 pills 3 times a day. So you could be taking a gram 3 times a day or 4 times a day, or maybe even more. You might be taking 2 or 3 grams 2 or 3 times a day. So remember that what we're filtering through our kidney is 10 grams. That's a lot of calcium that we filter through our kidney, and we reabsorb all that. And there are multiple hormones that regulate calcium reabsorption through the kidney. The main regulator is parathyroid hormone. And with the presence of normal parathyroid function, we're able to bring that calcium back. 9.8 grams are reabsorbed. So we only lose about 200 milligrams in the kidney, through the kidney, in the urine. And so if we don't have parathyroid hormone, all that calcium is going to be lost through the kidney. We're not going to be able to efficiently bring that calcium back. And this is one of the problems with hypoparathyroidism, is that when you don't have parathyroid hormone, we're losing large amounts of calcium through the kidney. Look what else parathyroid hormone does. When serum calcium goes down, it's sensed by the calcium sensing receptor sitting on the chief cells, increases PTH, bring back that calcium. The second thing that it does, that happens within minutes, we're able to bring that calcium back. And then within hours, we're able to stimulate bone resorption. So we're able to get the calcium out of our skeleton. And I'll show you in a few minutes how parathyroid hormone is able to get the calcium out of our bones. But our skeleton is a bank for calcium. We also store phosphate in our skeleton, and we also store magnesium in our skeleton. And so when we need calcium, we reabsorb it from the kidney and we get it out of our skeleton. And if we don't have PTH, we can't reabsorb the calcium through the kidney and we cannot get it out of the skeleton. And the next thing that happens with days, with the calcium still being low, what will happen is that we're able to take our vitamin D and activate it and form 1,25 dihydroxyvitamin D, which is calcitriol. And if we don't have adequate levels of PTH, we're not able to form calcitriol. And it's important for us to recognize that if we don't have PTH, the standard of care has consisted, well, let's give back calcium. Let's take lots and lots of calcium by mouth because it's not going to be reabsorbed through the kidney and we can't get it out of the bones. And we also give calcitriol, 1,25 dihydroxyvitamin D, because people who don't have PTH or in whom the PTH function is not normal, in those individuals, we have a deficiency of 1,25 dihydroxyvitamin D, which is calcitriol. So what happens in the blood is the calcium levels are low. And another important factor that we need to consider is that PTH, it reabsorbs calcium through the kidney, but it also removes phosphate. And so if we don't have PTH, then phosphate is not being cleared through the kidney. And so phosphate levels rise. Now, why is that important to know? Well, when phosphate levels rise, it binds with calcium and it can cause calcium deposits in other areas of the body. It can cause calcium deposits in the brain, and it can cause it to happen in parts of the brain called the basal ganglia. And it can cause problems with brain function over time. It can cause calcium phosphate deposits in the kidneys, and it can cause calcification of the parenchyma of the kidney or the kidney tissue itself, as well as kidney stones. Filtering all this calcium, not being able to reabsorb it, causes kidney stones. And these are the complications that people with low parathyroid function can develop. So if you don't have parathyroid function because the parathyroid glands were taken out, or you have other diseases like genetic disease or autoimmune disease or a resistance to the effects of PTH, the net result is that we don't have adequate parathyroid hormone function. And if we don't have parathyroid hormone function, then we're losing calcium through the kidney. We're not able to get rid of phosphate. The calcium can cause calcium deposits in the brain, in the kidney, can cause kidney stones. You can also get cataracts developing in the eyes. body needs calcium to function. So if we don't have adequate calcium, it can affect our nerves. The nervous system needs calcium, so patients develop numbness and tingling. I can see your mouth moving, but
sorry, I didn't realize how to unmute. Dr. Khan, we have a question that we think might be pertinent now. Someone is asking, well, we have two questions. One is this information relevant to pseudo-hypoparathyroidism or just to normal hypoparathyroidism?
Oh, it is relevant to pseudo-hypoparathyroidism as well, because as I mentioned, we need to have normal levels of parathyroid hormone and function. And in pseudo-hypoparathyroidism, we have a deficiency of a signaling protein that links the receptor to adenylate cyclase, which is the enzyme that allows parathyroid hormone to carry out its work. So it's like hitting on the door, but the door is locked.
Okay, and someone also asked, is it possible to develop pseudo-hypoparathyroidism after a thyroidectomy?
Well, they can be coexisting conditions as well. And so a patient may have had pseudo-hypoparathyroidism, and then they went on to have a parathyroidectomy. So you can have coexisting conditions develop as well.
Okay, thank you.
You're welcome. Okay, should we go back to the slides? Okay, I will minimize this. I think what we'll do is we'll actually keep the questions at the end because it might make it easier to have smooth flow. Here we go. And so as I was explaining, so when the phosphate levels are high, then this can cause calcium deposits to develop, and it can damage kidney function. So what are the acute complications of having a low serum calcium? Numbness and tingling in the face and hands, and it can cause muscle cramping. It can contribute to a seizure. Some patients can present with a seizure. And it can also affect lung function. It can cause bronchospasm, laryngospasm, and so you can get wheezing. It can affect the heart function. It can cause congestive heart failure. It can cause cardiac arrhythmias or irregularity in the heart function as well. And so those are the features of having a low calcium. Now, having a low PTH, there are PTH receptors in the brain, and some patients find that, you know, their calcium is normal, but their ability to think clearly is still not there, even though the calcium levels are normal. And we find that when we give back PTH, that this can result in significant improvements in cognition and quality of life and overall well-being. Now, the long-term complications of hypoparathyroidism include these ectopic calcium deposits, so deposits in the brain, deposits in the kidney, decline in renal function. And there may be effects on the skeleton because we're not able to take the calcium out of the skeleton. We're not repairing and renewing the bone. And so old bone can accumulate, and that may be associated with impaired bone quality. But our ability to understand what is actually happening in the skeleton is really limited right now. Our knowledge of the effects of hypoparathyroidism on bone strength is limited. So with this slide, I wanted to explain that parathyroid hormone binds to its receptors, the PTH receptors on the osteoblast, which are cells in the skeleton. And when it does that, it activates the cell, so it releases a signaling protein, which will then go on to activate another cell called the osteoclast. And the osteoclast attaches to the surface of the bone, and it releases acid and enzymes and digs out a hole in the bone. And when it does that, it releases calcium and phosphate that enter the bloodstream. So if PTH is not binding to its receptors on the osteoblast, it's not increasing the work of the osteoclast, so the osteoclast cannot dig out the bone, and it cannot release the calcium and phosphate from the skeleton. And that's why PTH is very important, because it enables us to be able to mobilize that calcium from our skeleton, and it activates vitamin D so that we can absorb calcium and phosphate from the bowel. And when our blood calcium levels go up too high, there's a natural impact on the calcium sensing receptor. The calcium will bind to the calcium sensing receptor, and it can turn down the synthesis and the secretion of PTH. And so when serum calcium levels rise, parathyroid hormone goes down. When calcium levels are low, parathyroid hormone levels go up. And so if we have a mutation in the calcium sensing receptor, and some patients can have a mutation which makes the receptor super sensitive, and those are people who have activating mutations in the calcium sensing receptor. And what happens in those individuals, it's such a super sensitive receptor that even though calcium levels are not higher than normal, they're still turning off PTH. And that results in a lower blood calcium. And in those individuals, in the kidney, the same receptor is super sensitive. So calcium is binding to the receptor and it is increasing urine calcium loss. And people who have this autosomal dominant hypocalcemia are more likely to have renal complications of hypoparathyroidism. And so, as you can see, we need to know why that individual has hypoparathyroidism. Most people who have hypoparathyroidism, 75% approximately, have it because of surgery, that the parathyroid gland was damaged or destroyed because the blood vessels feeding the parathyroid glands were interrupted. And it could be thyroid surgery or parathyroid surgery. And patients will present with all of these features. So if you have a low blood calcium, a low or inappropriately normal parathyroid hormone, a high phosphate, high urine calcium, and a low 125D, these are the features of a low parathyroid state. And as we've mentioned, usually 75% of them can have this because of surgery, but there are other causes as well, such as autoimmune disease. And we can have conditions where you can have antibodies to the parathyroid glands, and these antibodies and lymphocytes can move into the parathyroid glands and destroy the normal parathyroid function. We can also have conditions where the genes that regulate the formation and the function of the parathyroid glands are not working properly. And they can be associated with other abnormalities as well. And so your physician will do a very careful history and physical and evaluate why hypoparathyroidism is there. And they can be infiltration with other conditions like sarcoidosis and other granulomatous diseases. Cancer can very rarely spread to the parathyroid glands. The glands could be destroyed because of radiation, or copper or iron can deposit in the glands. If the magnesium levels are not normal, this has an impact on parathyroid function because magnesium also binds to that calcium sensing receptor. And if the magnesium levels are high, it can turn off PTH. And magnesium is necessary for the function of the parathyroid hormone at the tissue level. So if the magnesium levels are low, that has an effect, and it makes the tissues resistant to PTH. And so there are many reasons for the development of hypoparathyroidism, and it's important for us to do a careful evaluation and find out why you have hypoparathyroidism. And your doctor will do all of those tests and find out why parathyroid function is not normal. And this is what pseudo-hypoparathyroidism is. So it's a resistance to the effects of PTH. And it is because of a mutation in the gene that regulates how much of the signaling protein is present, which couples the receptor to the enzyme which allows the parathyroid hormone to have its effects. And so people who have pseudo-hypoparathyroidism actually have a low blood calcium. They will have normal vitamin D levels. They will have high phosphate because parathyroid hormone is not able to eliminate the phosphate, but their PTH levels are actually high because the effects of parathyroid hormone on the tissue is decreased. And we've recently published recommendations for what physicians should follow. How often should they be evaluating patients? How often should they be monitoring the blood calcium and the phosphate levels and the vitamin D levels? Which imaging tests should be done? How should they be treating patients who have hypoparathyroidism? And these recommendations were recently published last year, and they describe with global involvement, we had representations from around the world, how people should be treated today. What is the standard of care? What should patients be offered today so that no one can say, well, I don't know how to treat hypoparathyroidism. There's a lot of literature. And prior to this paper being available, the European guidelines were published and the international global recommendations were published. And we're now working on developing new recommendations because new therapies are becoming available. And our knowledge of bone biology and the effects of hypoparathyroidism is increasing on a daily basis. So we're in the process of pulling together a team of about 80 experts from around the world, and we're in the process of developing new recommendations. So it's very important for us to recognize that if we don't treat hypoparathyroidism properly and keep that calcium as close to the normal reference range as possible, keep that phosphate in the normal reference range, keep that urine calcium in the normal reference range, then our patients can go on to develop complications. Their kidney function can go down, their brain function could be affected, they can have symptoms, and they will not do as well in the long term as they would have if we were monitoring them very closely and ensuring that these lab parameters are being followed and maintained in the normal reference range. And we've talked about the fact that people who have hypoparathyroidism can end up going to the hospital because of seizures. They could end up having complications from the hypoparathyroidism, and they may also have other conditions which are more common, such as anxiety, such as depression. They may be more likely to have infections as well. And we know that 1,25 dihydroxyvitamin D, which is calcitriol, actually has an important role in the immune response. And so it is important for us to recognize that we need to make sure that patients are being carefully evaluated and treated. And when we are treating patients with calcium and calcitriol and correcting the deficiencies, we actually see reductions in these infections. And also when we give back PTH, we're allowing the body to naturally form their own having fewer infections on therapy than they were prior to starting therapy. The research that has been done has shown us that people who have hypoparathyroidism can have poor quality of life, and we have not yet confirmed that this condition will affect mortality. Some research indicates that it may reduce your life expectancy, but we haven't seen that seen consistently throughout all of the studies that have been done. For example, in the Scottish study, we did see an impact on mortality, and we haven't seen that in other studies. And when we know that if your blood calcium is too high, then it will have an impact on kidney function. And if the blood calcium is too low, then it will have an impact on the nervous system and the irritability of the nerve cells. So numbness, weakness, tingling, seizures can develop. And so normally when the parathyroid function is present, then we have a normal calcium level. But when you take the parathyroid hormone out of the picture, then you're ending up on a roller coaster. You have low blood calcium, we give you calcium and calcitriol, and if we give too much or we don't follow too closely, the calcium levels can go too high. And if your calcium levels are frequently going up and down, you can end up in and out of hospital. And that is very bad for kidney function, because the higher your level of calcium, the more frequent episodes of high calcium, that's associated with kidney failure. So it's important for us to recognize that we want to maintain that serum calcium in the close to the normal reference range. And we say in the low normal reference range, or close to the normal reference range, because when we give all this calcium and calcitriol, we don't want to increase the risk of long-term complications because the urine calcium can go up. And when we give too much calcitriol, phosphate goes up, and that makes the phosphate problem worse. Now, calcium is a really great way to bind the phosphate. So if you take calcium with your food, the calcium will bind to the phosphate that's present in the food, and it will get rid of it through the stool. But the more calcitriol that you take, it's a double-edged sword. Yes, it will correct your calcium, but if your phosphate is going to climb higher, it will increase your risk of long-term complications. So this is why when we evaluate patients and we look at management, our goals are to monitor patients frequently, try and keep those fluctuations down to a minimum so that serum calcium can be as close to the normal reference range as possible. And in pregnant women, it's important to keep it in the normal reference range, in the mid to the lower normal reference range, because remember, if the pregnant woman's calcium is not normal, it's going to have an effect on her baby's parathyroid function. And the baby's parathyroid function is going to be based on the mother's parathyroid function, the mother's calcium. So if we run that pregnant lady's calcium high, the baby's parathyroid function may not develop. And the baby may be born with low parathyroid function. If we run the calcium level too low and the mother is pregnant, then the baby's parathyroid function will become excessive and the parathyroid glands will become larger than they should be. And this can actually result in demineralization of the baby's skeleton and result even in fractures. So it's very, very important for our pregnant patients to make sure that you're concerned about your blood calcium. And we recommend in our guidelines that the blood calcium in pregnancy should be monitored every 3 to 4 weeks. And that if there's changes made in your medication, that the blood calcium be monitored even more closely, maybe within a week, because we don't want to have these fluctuations in blood calcium. If the calcium is too high, it's harmful. If the calcium is too low, it's harmful. And in pregnancy, if the calcium is too low, it can cause uterine contractions and preterm delivery. And many of our patients who have been pregnant tell us they had pregnancy loss before, they had miscarriages before. And for my pregnant patients, I like to see them at least once a month. And I'm monitoring them very, very closely. The outcome of that pregnancy will depend on a team approach. The most important person is you. And the second most important person is your endocrinologist or whoever's following your blood calcium and your obstetrician. And you should also have the pediatrician involved so that they're aware that there's a baby who has to be evaluated as soon as they're born to make sure that that baby's well and that baby's calcium is not abnormal. So it requires a team approach, but I cannot emphasize how important it is for pregnant ladies to be on top of their calcium. Please monitor your calcium, follow your medications closely, and if you're not happy with your medications, talk to your doctor so that they can be adjusted so that your calcium is in the normal reference range. All right, so what are the goals of therapy? We want to prevent the signs and symptoms of a low blood calcium. We don't want our patients to have numbness and tingling and muscle cramping, and we don't want them to have seizures. We don't want them to have cognitive issues. We want to make sure that they're as optimally managed as possible. We want to keep the calcium in the low normal or just slightly below normal. We want to keep that phosphate in the normal reference range. We want to make sure that the urine calcium is not high, and we want to make sure that the blood calcium isn't high. And patients do require calcium supplementation, and the calcium supplements that we recommend are calcium carbonate or calcium citrate. Now, patients find that calcium carbonate is easier to take because there's a larger amount of calcium per tablet. But calcium citrate may be easier to tolerate for some patients, and it depends on your individual preference. But it is important for you to discuss with your doctor. If you're having problems with your calcium, talk to your doctor and communicate with your doctor. But you need to take your calcium, and the best time to take your calcium is with your food, because the calcium has to bind to the phosphate in the food and get rid of the phosphate. So when you take your calcium, it's doing two things. It's giving you the calcium that you're not able to reabsorb through the kidneys and get out of the skeleton, but it's also binding the phosphate and it's getting rid of that phosphate. So the calcium is a critical part of the treatment strategy. And then we can go ahead and give activated vitamin D, calcitriol. Calcitriol is giving you back the hormone that we are not able to form because PTH isn't there. So PTH takes 25D and enhances the conversion to form 1,25-dihydroxyvitamin D. And if we don't have PTH, then we have two hormone deficiencies. We can also use alpha calcidiol, but I don't like to use alpha calcidiol because it's not as potent as calcitriol. It has a longer time for offset. And that means you're more likely to develop toxicity or high blood calcium if you're taking too much of it. It will take a longer time for that calcium to normalize. So I put all my patients on calcitriol. Hydrochlorothiazide is useful because this water pill helps us to reabsorb the calcium through the kidney. And we have to remember that in younger people, it can cause the blood pressure to fall. So we start off with very low doses of hydrochlorothiazide, and we also monitor potassium because hydrochlorothiazide can cause you to lose magnesium and lose potassium. We also have to make sure that the magnesium is corrected. A very important part of the management is making sure that the magnesium is corrected. There are different types of PTH molecules. Now we can give back PTH. PTH can be given in the form of teriparatide, which is available. That's PTH 1 to 34. Now, PTH 1 to 34 has a short half-life, and so when it's given, it's ideally given twice a day, but even taking it once a day can make a difference in your management, and it can enable us to reduce the amount of calcium and calcitriol that is required. And if it's taken twice a day, you may very well be able to stop taking calcium and calcitriol totally. We also have PTH 1 to 84, which is available, and PTH 1 to 84 was approved by the FDA in 2015, and PTH 1 to 84 has a longer half-life than PTH 1 to 34, and it can be given once a day, or it could be given twice a day. Now, PTH 1 to 84 has been withdrawn because of rubber particles in the solution, and we do not have PTH 1 to 84 in Canada. So we've talked about the different formulations of PTH, and we have the 1 to 34, which has a half-life of an hour, 1 to 84, which has a half-life of 3 hours, and we recently did a study looking at giving PTH 1 to 84 twice a day and in comparison to once a day, and we've looked at that, and we've looked at the effects on urine calcium because we want to normalize that urine calcium. We want to bring that phosphate down into the normal reference range, and there is another molecule that is now being evaluated in clinical research called the TransCon PTH, and this has a half-life of 60 hours. And basically, TransCon PTH is PTH 1 to 34, but it's connected to a polyethylene glycol molecule, which allows it to be gradually released, and it has a half-life of 60 hours. So it gives us a very stable a level of PTH in the bloodstream. And then this polyethylene glycol molecule is just cleared through the kidney. Okay, so the studies that have been done with these molecules have shown us PTH 1 to 34 has been effective in improving calcium and vitamin D requirements by lowering them, and it can decrease the urine calcium. And when we give it as a pump, it was shown to be more effective than giving it just once a day or twice a day, and it appears to improve quality of life. And PTH 1 to 84 has been evaluated, and this has been shown to reduce the requirements of calcium and vitamin D. It can bring that phosphate down into the normal reference range, and in longer term studies, it has been shown to improve urine calcium as well. And we do have 8-year data now with PTH 1 to 84 showing us that it is a safe molecule to use, because with these PTH molecules, there was a study done in rats with PTH 1 to 34 that showed us that when it was given in toxic doses, 60 times the dose, the rats got osteosarcoma, which is bone cancer. But no human has had an increase in the risk of bone cancer. So the risk of bone cancer with PTH is about 1 in 250,000. And people who have been on PTH, we have more than 1 million people on PTH now globally. There is no increase in the risk of bone cancer in people with PTH. And we have long-term data as well with PTH, and PTH has not been associated with an increase in the risk of bone cancer. But there is a black box warning on the PTH box that says that this is not to be given in people who have had cancer or radiation. And obviously we don't give it if your calcium is high or your parathyroid hormone levels were high to begin with. But if you have not had cancer or radiation, then it is safe to take this medicine. And it is a valuable treatment approach to osteoporosis care today. Yes.
Dr.
Go
Khan,
ahead.
I just wanted to let you know we just have a couple minutes left if you're going to take questions, just a few minutes so that we have time for questions.
Yes, thank you. So I'm going to conclude by saying that parathyroid hormone is a very welcome addition to the treatment strategies for hypoparathyroidism. And it has been a very welcome addition because it enables us to reduce the amount of calcium and vitamin D supplementation that patients require. It has shown us that it is effective in reducing phosphate levels, and phosphate levels are critical for the development of the long-term complications. Parathyroid hormone has been shown to be effective in lowering urine calcium and improving quality of life. And we do have long-term safety data with parathyroid hormone. So with that, I'd like to conclude by saying the bottom line is close monitoring, good patient communication with your physician, and it involves working as a team. And, you need to have mutual respect and understanding. And with that, you should do very well with the management of hypoparathyroidism. So with that, I'd like to thank you for your attention and answer any other questions that you may have.
Thank you, Dr. Khan. Okay, one of the first, let me go back to the top of the page here. It says, my PTH is generally between 3 and 4. At that low, would my body be converting any meaningful amount of vitamin D or managing my calcium phosphate levels?
Well, there will be some we really need to be guided by the lab. So we would look at the lab profile and we would adjust the dose of calcitriol based on what's happening with the lab profile. But we never look at one parameter in isolation. So we would look at everything. We would look at the calcium, the corrected for albumin, we'd look at the phosphate levels. We would measure the 25 hydroxyvitamin D, make sure that that is normal. We can measure the 125 dihydroxyvitamin D levels and also look at the urine calcium.
Okay. And the next question is, what is considered too high of a phosphate level?
So if the phosphate is higher than the normal reference range, then that would be considered too high. But right now we've done a big study in Canada where we've looked at, we have a registry of patients with hypoparathyroidism, and we looked at correlations between calcium phosphate product and phosphate and urine calcium and the development of basal ganglia calcification and kidney calcification and kidney function. And we found that even if you have a calcium phosphate product that is normal, even if your phosphate is normal, you may actually have these complications. So this is a moving target, and we really need to redefine what is the ideal calcium phosphate product. But right now, from what we know as of today, I would say keep that phosphate in the normal reference range.
Okay. And the next question is, what about PTH replacement options for children under the age of 18? This person has a 7-year-old with already showing calcium deposits in their kidneys.
Yeah, that's a very good question. And I would say that PTH is certainly an option. And we do have data with PTH in children, especially in a child who has renal calcification. This is something that can be considered and discussed.
Okay. How do you go about getting your local doctor to check for kidney stones? I get turned down when I go to my local doctor. I have brought info about HPTH, but they refuse to check for kidney stones.
Right, so the reason why we developed the standards of care was specifically for this problem. So a standard of care defines what is essential for the physician to do in terms of providing care for patients with hypoparathyroidism. And so we defined what needs to be done. So if you like, you can take a copy of that standards of care, and it's posted on our website, and take it to your doctor and say, this is the standard of care. And I need to have these tests done because this is the standard of care. So a guideline is different to a standard of care. A standard of care defines what is necessary for your doctor to do. And we publish those standards of care in collaboration with our international colleagues. And we said that it is necessary to look at renal function. It is necessary to look for the development of renal stones because we modify the treatment based on the presence of these complications. So it's absolutely critical. Go ahead and print those off and take it to your doctor and say, I need to have my care meet the standard of care. Can you please refer me to someone who can provide the standard of care?
Okay, that leads into the next question. Someone said that they have printed out the standard of care before. They are a patient from Canada. And is there a better way to get the word out to providers in Canada specifically because they've taken the standard of care and the physician has refused to look at it or use it?
Well, I think you need a different doctor then. And you need to find someone who's interested and involved. And we certainly can provide a list of physicians who are specializing in the management of hypoparathyroidism in Canada, province by province.
Okay. How often should someone have their phosphate levels tested?
And that's a very good question. And that is, it depends on the quality of care that you're receiving. It depends on your control. But typically, I would say at least every 6 months, it should be monitored. I would say at least every 6 months. And some patients, we have to monitor it more frequently. In other patients, we may not monitor it that frequently.
Okay. What type of magnesium is best tolerated?
So there are different types of magnesium supplements. I find that my patients like magnesium rouge, which is a liquid magnesium preparation, but it can also be given in the form of pills. Whichever form you like. You may like one and not the other. It's important to monitor the levels and ensure that magnesium is normal, because magnesium deficiency has an impact on parathyroid function. And if there's a reason for the low magnesium, that should also be corrected. Because some patients, as we've mentioned, if they have a mutation in the calcium sensing receptor gene, they can lose significant amounts of magnesium through the kidney. And for these patients to go on a proton pump inhibitor is a big problem. So it may not be possible to normalize that magnesium because the more magnesium you take, it can irritate the bowel and cause diarrhea. And so you need to discuss the optimal management of magnesium if magnesium regulation is a concern. But this is where you need someone who is going to take the time and look at all of these aspects and normalize them. And the standards of care will be helpful in that regard because we outline the importance of addressing each of these issues.
Okay, and I just want to say that we will also make sure that those standards of care get posted on the Hypopara website for people who are looking for them.
Thank you.
The next question is, you were discussing the difference between PTH 1 to 34 and 1 to 84, and they would like to know what the extra 50 amino acids in 1 to 84 actually do.
All right, so basically they have a different half-life. The molecules have a different half-life, and they have, because of that different half-life, that will have an impact on the dosing and the response in individual patients. But if you look at the action of the molecule is present in 1 to 34 as it is in 1 to 84. And the impact of the molecule is really in terms of its response in individual patients.
Okay. And someone asked, is PTH replacement safe for those who have a history of thyroid cancer?
Yes, PTH replacement is safe if you've had thyroid cancer. It is a situation where we balance the risks and benefits of good quality control and the type of cancer that you had and what has been your response to treatment for the thyroid cancer. So if you had thyroid cancer with an excellent response, and you have widely fluctuating calcium levels, then yes, you can go ahead and be treated with PTH. But it's an individual decision that has to be made.
Okay. Are there any supplements to help reduce urine calcium?
Well, the hydrochlorothiazide can help to reduce urine calcium. When we give more calcium and when we give calcitriol, that will end up in increasing urine calcium losses as well. But hydrochlorothiazide can help to enhance renal calcium reabsorption, and giving back PTH will help to lower that urine calcium.
Okay, someone asked, can you expand on what you mean by frequent monitoring? Is there a set interval or how frequent?
Well, that's a very good question. And it depends on whether you're stable or unstable, or if there's been a change made in your medication, or if you're pregnant. And so if you are an unstable patient and you've got wide fluctuations in calcium, you need to be admitted to hospital even if you've got a crisis situation, and we would be monitoring the blood calcium 2 or 3 times during the day. If you're well enough to be discharged from hospital, then sometimes we need to monitor every day as we're making sure that the dose of the calcium and the calcitriol is the right dose for you. And also when we're adjusting PTH, sometimes you need to monitor it every day until it has stabilized. Once it has stabilized, we can back off and we can maybe monitor once a month or then go down to once every 6 months. But it depends on the individual situation. Now, in pregnancy, what happens is we have PTHRP being produced by the placenta and by the breasts in a pregnant woman. And so in the pregnancy, the PTHRP goes up and the patient is able to produce their own natural 125D. And so we need to monitor these individuals very carefully because the response in each individual may vary. So in pregnancy, a patient may require more calcium or calcitriol, or may require less calcium and calcitriol. So a pregnant patient needs to be monitored at least every 3 to 4 weeks. That's absolutely critical. And when there's changes made in the dose of the calcium and the calcitriol, I will get my patients to check their blood work in maybe 2 or 3 days, and then be in contact with our office so that we're very closely following these patients and making adjustments in the doses of their supplementation. An important point to note, in pregnancy, hydrochlorothiazide should not be used, and in pregnancy, PTH should not be used. PTH should not be given in a pregnant woman, but calcium and calcitriol can be used in pregnancy.
Okay, Dr. Khan, I'd like to thank you for your time. Unfortunately, we're not going to be able to get to the rest of the questions. Due to time, we have to get ready for the next session. We will forward these questions to you, Dr. Khan, if you don't mind, and if you can answer them, we will get them posted to our website. So folks, if your question didn't get answered, which there's a lot of them, I have 47 more questions on here that did not get answered. We will try to get you answers and get back to you. But please join us at our next session in about 10 minutes. Thank you.
Thank you.
One second, guys. I'm just publishing these questions so that way they're part of the extraction. Then I'll end the event.
Oh my goodness, you did an awesome job.
There were so many questions coming in and I was trying to filter through what was duplicate and what was similar, and that was the most I've seen so far. That's crazy.
That was great. You did a good job, Michelle.
Okay. I was trying